Hello, everyone, and welcome to part 2 of chapter 6. We're going to continue our conversation concerning trauma and stressors in talking about dissociative disorders. Now, dissociative disorders are going to be disorders marked by major changes in memory that do not have clear physical causes. So this is focusing. Now, PTSD can have some dissociative components, the same with acute PTSD or acute stress disorders. But the memory issue, the depersonalization, the derealization, the troubles with having a wholeness and continuity in one's life, these are going to be markers of dissociative disorders. There's going to be like memory lapses. So for an example, if you've ever driven a car and kind of zoned out, you got to your destination and you were like, wait, I don't remember making that turn. I don't remember going down that street. How did I get here and not hurt anyone? I wasn't paying attention. That's kind of a normal level of dissociation, okay? So take that experience you've had and think if that were consistent throughout your life and your day-to-day interactions. That is going to be indicative of dissociative disorder. So as part of our identity or our memory is going to be separated from other parts of our identity and memory. So just like you don't remember that dissociative state in driving the car, that's what happens with people who have these dissociative disorders. So we're talking about dissociative amnesia. I'm sure we've heard of amnesia before. It's some kind of forgetting that usually happens as a result of physical injury. Well, remember, dissociative amnesia does not have anything to do with a physical injury. This is going to deal a lot with the psychological component. How do people forget certain things as a result of trauma? So usually this person who has dissociative amnesia, Dory's a good example from Finding Nemo. They cannot recall important life-related information, typically traumatic or stressful information, and the memory problem is more than simple forgetting. There's significant distress or impairment, and the symptoms are not caused by a substance or medical condition. So if someone is under the influence of different substances and having memory issues, that is not dissociative amnesia, okay? And same with a medical condition or physical injury. That is not indicative of dissociative amnesia. Typically what we find, there are 4 different types of dissociative amnesia, or, well, the forgetting aspect. There's localized, selective, generalized, and continuous. Localized is the most common, and it's going to be the loss of all the memory of the events within a certain period. So let's say someone experiences significant childhood physical abuse, not necessarily sexual in nature, but we'll just say physical abuse. They may not remember, let's say that it happened when they were 6 to 8 years old. They may not remember anything from a period from when they were 6 to 8 years old. Now, with selective dissociative amnesia, someone may remember some, but not all events within a certain time period. So maybe they remember let's use that same 6 to 8 years old example. Let's say that person remembers certain experiences, like their first time going to the carnival at 7 or something, but they may not remember the actual trauma itself, okay? So it's very selective in nature. When you have generalized dissociative amnesia, it's an inability to remember events prior to significant trauma. So this is affecting things like your identity, your friendships, your relationships. So it's sometimes these things are integral to understanding who we are. So it's forgetting those early experiences prior to the trauma. And then we have continuous, which is kind of like Dory in a sense. She says she has short-term memory loss. This is forgetting continues into the present. So after trauma, maybe that person has a hard time maintaining different memories. They keep forgetting present things that have happened. This dissociative fugue is a type of dissociative amnesia where pretty much someone forgets their identity, who they are, and kind of picks up and leaves, and they assume a different identity and carry on life as normal without recognizing that they are actually someone else. I know that sounds a little confusing, but I've included a great clip on dissociative fugue on this woman named Hannah, who is still, I think, still currently missing. I would have to check, but she went into a fugue state twice, and the first time they were able to find her, but not the second. So check out that video. It's very interesting. Next, we're going to talk about dissociative identity disorder, or DID. It was formerly known as multiple personality disorder. Okay, there's a lot of stereotypes surrounding this psychological disorder, and it's highly controversial in the field of psychology itself. Some therapists don't believe it really exists, but maybe it is suggested to different clients by their therapists unintentionally. It's very controversial, and this video is so great. Oh my gosh, her name starts with an M. Dr. I think it's Marks or something, Markham's. Anyway, she discusses dissociative identity disorder, and this video is just an excellent resource. I love it. That's why I put it on this slide. But please watch it because it gives you a good, oh, her name popped up. What's your name? I did have it, Dr. Tracy Marks. Anyway, check it out. She just does a fantastic job of describing DID. We're going to talk about it now, but hearing her professional perspective is always helpful. So, when someone has multiple personality disorders, what is going on? We've seen the preview for the movie Split, where the guy has multiple personalities and he's a serial killer. I feel like multiple personality disorder is always portrayed as someone being violent or like ready to harm people. That is not necessarily the case. That is a horrible stereotype because, well, first of all, like less than 1% of the population have been diagnosed with dissociative identity disorder, and a lot of times they're not trying to harm other people but have experienced significant trauma themselves. But typically with dissociative identity disorder, the person's going to experience a disruption to their identity, and usually they have two separate personality states or experiences of possession, they call it. They're also going to have experiences, like repeatedly, experiences memory gaps regarding daily events, key personal information, or traumatic events, and this is beyond ordinary forgetting. Sometimes when they transition between those personalities, it causes lapses in memories as well. Significant distress or impairment, that is going to be a big one for a lot of these, and the symptoms are not caused by a substance or a medical condition. So there's no underlying substance abuse issues or physical or other medical ailment. Now, important concepts related to dissociative identity disorder. People who are diagnosed with this disorder have two or more personalities, right? And these personalities can have so many different identifying features. They could change in race. They could, they can take on different personas of stereotypes of race, genders, ages, abilities, and preferences. Sometimes when people transition between their personalities, one personality may be able to, let's say, play the piano, whereas the other one cannot, right? There's different abilities and preferences. It's like having different whole people and personas these people take on. And I thought this was fascinating. There's even different physiological responses. So what do we mean by that? There are differences in heart rates, for example, between someone switching into their different personalities. So one person may have a higher general heart rate, one of their personalities, as comparative to another, which I think is just really fascinating to me, and I would love to know how they tested that. If I find a study with that, I'm sure it's listed in our text. I'll put it in our supplementary documents folder. But the idea that someone's different personalities, we think of them as, oh, well, they're one person. They should know what's going on in their body, but their physiological cues being different in their different personality states, I just think that's really interesting. There's usually going to be a primary host personality, and that's really important for the therapist to specifically make contact with when they're trying to blend the personalities of the person together. The relationships between the subpersonalities can be different depending on the person. So when we say mutually I don't know if I'm saying this word right, amnesic relationships, that means amnesic, right? We're talking about forgetting. The personalities don't know about one another. Sometimes the personalities are mutually cognizant patterns. They all know about one another and what's going on, like in terms of preferences, things of that nature. One-way amnesic, which means kind of like the host personality, kind of knows all the other personalities, but the other personalities don't know each other. And conscious subpersonalities, where the subpersonalities are kind of aware of one another, but they don't try to intervene when one personality takes over. But there may be some unconscious behaviors of one personality that manifest when, like, let's say the host personality is a young child who's very jovial and happy, but then there's another subpersonality of that's a grumpy old man who's not happy, right? Let's say that jovial child personality is currently the predominant personality the person is exhibiting in a therapeutic session. Well, if the person is being confronted with their trauma, because stress and traumatic events can trigger someone to switch between their personalities. So let's say the therapist starts talking to, let's say, Joe, and Joe is currently in his jovial little girl personality and acting very childlike. Maybe components of his grumpy old grandpa personality are seeping through. Maybe those different behaviors and cognitions are trying to make themselves known in his childlike personality. As you can see, it can get very complicated with the relationships and the subpersonalities that people maintain. There are a lot of case studies in this. Again, it's very controversial because people believe it's iatrogenic or brought about by a therapist. They think that because these people are highly suggestible, it could be that they've kind of hypnotized themselves into a motivated forgetting-like state. And we're going to talk about that right now with theorist perspectives and dissociation. So typically from the psychodynamic view, we talked about defense mechanisms, and repression is one of them. It's called motivated forgetting. And so the idea behind Freud was that with dissociative identity disorder and amnesia, people were kind of motivated, their unconscious was motivating them to forget their trauma. And as a result, it resulted in lapses in memory and just either an excessive episode of repression, or excessive lifetime repression. So with DID, it could be that the person was excessively repressing different traumatic events. Maybe it occurred over a long period of time, right? And so with that excessive repression, they developed those other personalities to kind of, I don't want to say fill in the gaps, but it could be. And then amnesia, they're just repression, motivated forgetting. They want to forget the trauma and anything surrounding it. That was Freud's view, which was very important at the time. Again, it brought attention to traumatic experiences when we weren't really certain of the effects. Cognitive behavioral view is kind of looks at the different perspectives. State-dependent learning is related to this. So it's remember, we're looking at cognitive patterns and behavioral patterns. Well, in psychology, we've come to know something as this theory of state-dependent learning. People can learn different tasks in different states. For example, if you teach someone something when they're really drunk, let's say a little party trick, they may not be able to remember it when they're sober. But if you get them drunk again the next day, they may be able to remember it because they are in a state that they were in when they learned it. Okay? And there's this idea that there may be state-dependent arousals. Okay? And so the idea is that in different states of consciousness, people can kind of exhibit different levels of arousal. And if someone experiences too much arousal and it falls outside of the realm of what they consider normal, there may be a point to where they kind of have a motivated forgetting type of stress response to dissociate from the situation, because the level of arousal is not one in which they've adapted to, and they're so rigid in what they can handle. So these state to memory links are really rigid and narrow, and it may cause a dissociation because they just can't deal with so much arousal, if that makes sense. So if an event is particularly too traumatic or traumatizing, and they're too rigid in the way they deal with their stressors, it may cause them to dissociate. If you need clarification on that, let me know. I tried to be as clear as possible. And self-hypnosis is just the idea that someone is able to dissociate or separate from the world around them by activating a sort of hypnosis within themselves. So if a child is experiencing excessive trauma in childhood, whether that's physical abuse or whatever it may be, maybe they claim that they went to a certain window to sit and look out the window because it made them happy. Well, that looking out the window is focusing on one particular stimuli, and that focusing on that one particular stimuli is able to help them dissociate or separate from the world and bad feelings around them. And so it may be they're kind of hypnotizing themselves to dissociate out of that state and forget those unpleasant events. With that being said, sometimes we can use that to our advantage as hypnotherapy for the treatment of dissociative disorders. For dissociative amnesia, you can use hypnotic therapy, drug therapy, psychodynamic therapy. We talked about psychodynamic therapy extensively, but drug therapy in particular, barbiturates. These are called truth serums, okay? But they're really not truth serums. They help the person relax. So the thought is that if a person is really relaxed, they can kind of let their guard down, in essence, so to speak. They can become so relaxed that they can kind of access certain parts of memories that they may have repressed on some level in like a higher state of arousal or consciousness. A lot of these techniques are supported by case studies. So what are your thoughts on that? Do you think more evidence is needed? Do you think case studies are significant enough? Just a question to you. And for dissociative identity disorder, it's helpful. We want to help the person recognize fully the nature of their disorder, like what is going on. So the therapist will often bond with the primary personality. Okay, that's important because they want to recover those gaps in that person's memory to find out what happened with their trauma and help the person work through it, right? And then there's also an additional component of trying to take those subpersonalities and integrating them into one functional personality. It's very difficult, right? And even after that has occurred, it's important to continue the therapeutic session so that that person doesn't kind of separate once more. Then there's the topic of depersonalization and derealization disorder. It's similar in the sense that someone's separating from the world around them, but not in essence of forgetting things. That's an important thing to note. There's a case study on page 185. Please check that out because it has some key terms that are going to be indicative of this disorder, including not connected to body and doubting reality. So depersonalization is this idea that we don't feel at one with our body and our experiences or our identity. And then excuse my typo on there, I gotta fix that. And derealization is just kind of how it says. They're doubting the reality. So sometimes people make a joke on social media that we're in a, what is it called? We're in a simulation, if y'all have ever heard that before. So some people say that as a joke, but for other people this can be triggering for depersonalization and derealization disorder, causing them to second guess their realities. And this can also be triggered by extreme fatigue, physical pain, intense stress, and recovery from substance abuse. So there's a lot of negative things that stress can do to our body physically as well as psychologically. And so getting a handle on trauma and stress is important to understand those different triggers and the effects they have on our biological pathways. And it's important to look at all of those biological, cognitive, behavioral, family, and group interventions for people with acute and post-traumatic stress disorder, as well as dissociative disorder, right? And this is quickly being developed with the resurgence in PTSD that we're finding in people as a result of particularly combat and sexual assault and rape. Dissociative research is a little slower on the draw, although it's increasing because of certain enthusiasm. But our text cautions us that this resurgence in research may give a false impression of prevalence, like saying the number of people who have this is more prevalent than it actually is. So just a tale of caution. But again, highly controversial with dissociative identity disorder in particular, because even a lot of professionals in the field doubt the existence of the disorder and that it may be a result of something else. There are a lot of variables to understand with stress, including biological, childhood experiences, personality styles, and social supports. And so that's what we get into with our discussion question, particularly in the case of PTSD. What factors can lend themselves to someone developing PTSD? And while I generally went over it in our lecture, I want you to really think about it with our reading, really details this for you. I look forward to hearing your responses, and I hope you all have a great week.